Are live here. So this is our March edition of our provider Facebook Live. So really excited to be joined today by Dr. Mario Palomino from Palomino Physical Therapy. Fairly new office in town, doing some really cool stuff. And we had talked to Mario and Leah before, more focus on pelvic floor type of specialty that you guys have as well. But I know today we wanted to dive into some different topics. So just real quick, for people who don't know you, aren't familiar with your guys' practice, do you want to give a little background, kind of how you got here, what you're focusing on, and then we can kind of dive into today's topics?
Yeah, most definitely. And again, you're right. We've been here before. Thank you for having us here, Dr. Konas. Great way to reach patients, and that's what we're trying to do ultimately, right? Spread the word. So with that said, Lee and I, man, we met in college. We were both cross-country and track runners, so we've always been around the fitness industry and healthcare model for a while. She's obviously a PT as well. After we graduated, we worked for the same company for a while, downstate, Novi area, Royal Oak. Did some directorship, things like that, running clinics and learning the ins and outs of the business. But it was also a nice opportunity to work with a wide range of patients. I mean, Metro's a pretty diverse area, Metro Detroit. And there's a lot of clinicians, but we're outnumbered by patients. So I know we're going to talk about neurodegenerative diseases today and Parkinson's. And that's really how I got started with Parkinson's. It wasn't something I ever intended to treat or be around. But man, there's a big need for it. And so I was exposed that way. That was kind of the same way Leo was exposed to pelvic floor. There was just a big need for it. We got our feet wet, and then, you kind of end up loving what you do and you get better at it, and the cycle repeats.
No, that's awesome.
So yeah, all that. And then the dream was always to come here, Dr. Konas, be in Traverse City, beautiful TC. Leah's originally from this area, family in Cadillac. And man, we just come up here every summer. We got friends up here. It's a beautiful place to be. I don't blame people for wanting to live here.
No, that's awesome, man. Well, we're glad to have you. The community is lucky to have you guys. So I'm excited that you're here, and getting to know you over this short time has been great. So like we said today, we're going to talk a little bit about Parkinson, some neurodegenerative disorders, and, probably we'll get into some dry needling talk. So we'll kind of bounce around a little bit. But starting out, I know you have a Parkinson's certification. Do you want to start off maybe touching on what that is, and then we can go from there?
Most definitely. So there's quite a few certifications. I mean, I was going to say just around neurodegenerative and Parkinson's, but it's a whole gamut. I'm sure chiropractic's similar to PT. Sometimes I don't know if the consumer knows the credentials behind the name and what they even matter. The one that I have is LSVT, Lee Silverman Voice Treatment. It's probably the most common, definitely one of the more common. There's the big and the loud treatment. So the loud treatment is more of a speech pathologist point of view or perspective. A lot of literally shouting, talking loud, exaggerating movements, facial expressions, as you see me doing, big eyes, sticking their tongue out. Because as we know with Parkinson's and other neurodegenerative disorders, that's what happens. We get this mass face. We lose the inability to be emotionful, essentially. And then the big program of the LSVT is more of what I do. Just what it sounds like. Big movements is what we try to promote. It's a good foundation. It's not one treatment fits all. So we have this funny saying, you might have something like this too, Dr. Konas, but if you've met one person with Parkinson's disease, you've met one person with Parkinson's disease. And that is a big thing that hits home, because where I used to work and other places all across the country, if you're Parkinson's, this is the Parkinson's protocol. LSVT is not like that. On the surface, it may look that way. There is like a designed 8 exercises of movement. For example, one is a bowling ball type movement. Imagine you're at a bowling alley and you're going to draw back, swing the bowling ball, and you're going to do a lunge position. That's one of the examples, one of the exercises. But the key there is knowing how to regress it, progress it, make it specific to that patient, meaningful. Anyone can go through patterns all day long, but what are we getting out of it? What are we trying to achieve? So that's why I like my certification, because again, get that foundation, but man, you can get outside of it and do so many cool things with it.
No, that's great. And it's funny, when I went to undergrad at Western Michigan, and when I was there, part of my, I was an exercise science major, and we had to do a couple internships that were required, for us to graduate. And I was actually at, I believe it was Bronson Hospital there. And so weekly, you would go to a Parkinson's support group. And I would basically just help out. I was just an undergrad student, but I would just help out with the group and facilitate these kind of movements and exercises. And there's probably 15 patients in this little gym area, and we'd have them go through different things. But what I do remember that really just triggered that was you saying it can be different for everybody. Like obviously there's the common symptoms and the shuffling gait and these different things, but everyone has different issues to a degree. And I just remember thinking like, wow, certain people are really struggling in this area, but they're actually still functioning pretty well in these other areas. So yeah, that hits home to me that everyone can be very different when it comes to that diagnosis. So let me ask you this, when it comes to you and you work with Parkinson's patients, how much of it is slowing the progression versus maybe trying to get an actual reversal or abatement of some of the symptomatology? Kind of what have you seen in your experience? Obviously, we know there's probably those miracle stories out there that are once in a long while, but what's really your goals of treatment, and what are you trying to do with these type of patients?
Man, that is the best question, because with that type of questions, a lot of other questions, right? If I had to answer that straight up, it would probably be to actually reverse some of the symptoms. Now, like, we're not curing Parkinson's by any means, but we're fixing some of the limitations that come along with it, to your point, like the functional limitations that you were doing in that group setting. Yep. These things do help people, and it's amazing because it's a central nervous system cascade more than it is, building muscle. So again, I'm going to go back to that same example of like a bowling ball type position where you lunge. I'm not really working on strengthening the quads in that lunge position. We're looking at coordination and balance and certain things firing. And it's amazing because, Dr. Konas, after they do that, they'll actually leave the clinic that day walking better. Now, again, this is because of a dopamine response. That's really what's happening more than anything physical. Excuse me here for a moment. I apologize.
Yeah.
Hi. How you doing? Doing good. Doing good. So we have a revolving door here. A lot of patients coming in and out. And I love our waiting room, so I'm hanging out in the waiting room.
Yeah, you're good, man. You're good.
But anyways, the position. All right. So I might do a lunge type position to strengthen someone's quads. I'm not doing it for these people. And again, because of that central nervous system cascade, it's a live change. Again, they're going to walk out moving better, and this is why we give them homework. But again, I'm not trying to strengthen anything. We're getting some secondary strengthening, great. But the ability to get in and out of their chair is not because they got stronger. It's because they got that central nervous system firing. And that's a lot of what we have, or we don't have, with people with Parkinson's. That dopamine's not being released. And I'm gonna go ahead and go one step further on a tangent. I apologize. That's also why we do this one-on-one. This is also why we don't switch therapists up. And as corny as this may sound, we love getting to know our patients, man, because again, what do you know about dopamine? It isn't just fitness. It's laughter, right? It's that feeling of belonging and community and enjoyment and sunshine. These are all natural ways to boost dopamine. So we try to incorporate all this stuff. I mean, it's not uncommon for me to take a patient outside on a nice sunny day, and we're going to do exercises out there because we're getting the sun, we're laughing. And again, their functional limitations will improve immediately. So sorry, a really long roundabout way to get to that answer.
No, that's great. I love that answer. And it's cool because especially when we see things clinically, right? Like there's obviously the research component to everything that you do and everything that I do. But clinically, like you notice certain things, you see certain things. And so like you're saying, like, hey, honestly, we're trying to reverse some of the symptomatology. That's similar to what, we try to do with different patients in our clinic. What's interesting too, from a Parkinson's perspective, it's not like in our office we're seeing Parkinson's patients on a regular basis or doing anything for that specifically. But it's funny because probably a month ago, I saw a case that came out recently from chiropractic biophysics, which is the technique we do. And, we're all about alignment and having proper sagittal alignment. So that just means, for people listening, proper alignment from the side, ear over shoulder, over hip, over ankle, and then from the front, just having a straight neutral alignment. But we know, especially say in a Parkinson's population or a lot of neurodegenerative populations, they're starting to get this kind of front leaning posture, right? They're starting to lean forward. What's interesting is when that happens, it affects the afferentation up into the brain. So our body, based on movements and positioning, feeds up into the brain and literally like gives the brain energy. It's like it feeds up there and tells the brain what to do. That's part of that dopamine response a little bit too, right? So
Absolutely.
what's interesting is there's actually a disorder called adult spinal deformity, and there's multiple criteria for someone to fit in that category. But one of the criteria is having an SVA over 50 millimeters. And what that means is that your C7, as you're standing or walking, is actually 50 millimeters in front of your sacrum. So just think of that classic person, like kind of like if they were using a walker, right? Like they're leaning way forward. That's kind of that position. What's interesting about that is there's now multiple published studies out there showing that if someone has adult spinal deformity, they score lower on long-term quality of life indicators than people with congestive heart failure, chronic lung disease, type 2 diabetes, and certain types of cancer.
Wow.
So what's crazy about that is if we can fix some of those alignment issues as well and actually fix some of that afferentation into the brain, that can just be, it can be so helpful functionally long-term for these people to not have to deal with stuff like that. And people just don't realize the musculoskeletal system, like how important that stuff is, but that's what it comes down to.
I'm glad you brought that up. That's such a good point that even myself as a clinician, I tend to forget sometimes, if I'm being honest. And that's the manual portion of treatment, right? And like you just said, everything you guys are doing, I don't know that that's being done all the time in a physical therapy situation, at least for Parkinson's, right?
Yeah.
They're Parkinson's. So we are doing things like the LSVT, which is not hands-on. I mean, I'm there to make sure no one falls, but I'm not taking them through range of motion. I'm not doing any passive stretching. I'm not doing any thoracic mobilization or anything like that, typically, unless there's pain involved or something like that. But that's such a good point. That stuff can't be neglected.
Yeah, no, it's great. So how about like other neuro disorders, right? Like you'll see potentially stroke patients, myotonic dystrophy, things like that. How does that correlate? How are some of the treatments or therapies you're doing that's the same, and how are they different?
Yeah, so you're right. We do treat kind of a wide range of different things, and I'd be lying to you if I told you that every time we get a patient with something, I know what it is, because I don't. So I'm going to give you an example. I had a retired physician. He was in his 80s that I treated downstate for a while with myotonic muscular dystrophy type 1. I'd never heard of it at that point. I'd do a lot of research. And again, he was a physician, so he was also very educated on his own disorder, and we had great conversations. I tried everything under the sun with him. I got to treat him as an experiment, and I was truly shocked by his results. I like to undersell and over-deliver. It's a little secret of mine. Even if I'm confident with the patient, but with this guy, I really didn't know. Look, I don't know if I can help you. I'm willing to try all this, but I'm going to be transparent with you and tell you, I don't know if this is going to work. So we did it, and we started out on a plan of care, and I found that he did better. All right, let me describe the disease too. Sorry. It was more of like a typical muscular dystrophy, like a Gower sign, unable to get off the floor, not very strong core or legs, upper body pretty strong. He did walk with a cane, but bent over very, very far forward. Like he looked like I was looking for a penny all the time on the ground. So very similar to the posture you were discussing. Not a lot of pain, just very stiff, slow, unable to move. I was trying exercises with him, a lot of the LSVT things originally, and I ended up having more success with my hands-on therapy with him. So I was doing a combination of neural stretching, manual, muscular, fascial stretching, all sorts of things. But I'd spend a good hour working on him. I wouldn't do any high velocity manipulations with him, but I did do some cervical mobs with him, traction, things like that. And same kind of thing. It was amazing. This guy would get off that bed. His bed mobility was better. He could put his shirt on and raise his arms all the way up, things that he couldn't believe. He's breathing better as we work through his diaphragm and his rib cage. And the reason I wanted to bring him up is that's not how I would have intended to treat him. It took some trial and error. And I think that's the point I'm trying to get to here. We treat a lot of different diagnoses, but we treat the person first. And that gives us the opportunity to figure out what is going to help them the best. Again, I didn't cure this guy's muscular dystrophy, not even close. He's on tons of medications and a barrage of other things he's doing, but he's walking better. He's getting dressed better. He's not using a cane anymore. And those are big wins. You know what I mean? And it's the ability to be able to step back and say, do I need to be an exercise based? Does it need to be mobilization based? It's cool to be able to wear all those different hats with these types of diagnoses. Same with a stroke.
Yeah. No, that's awesome. And I think that really gets overlooked. I guess it depends on, what part of the medical sector we're looking at, or even if it's with patients or what they've been told by their physician, maybe, or their even like their primary care sometimes, or neurologist or whatever it is. It's like, oh yeah, there's, really nothing you can do for this. You're stuck with this condition. Is
Yeah.
what it is. We hear that all the time with like peripheral neuropathy or someone that's got a L3 to L5 fusion. Oh yeah, you'll just always have low back issues. You'll never be able to help it, just whatever it is. And it's like you said, we're not saying we're curing these certain things, right? Like,
Right.
I know when you work with patients, when we work with patients, but if you can get functional improvements in their life, like that's literally what people care about, right?
Right.
It's like, it's not about just having this condition or just having this pain or whatever it is. It's like, how is that affecting your life? And how is that stopping you from doing things that you want to be doing? So if you can go from not being able to dress yourself to dress yourself, like that's amazing.
Right.
If you can't take a shower, now you can shower. Like those things are such huge wins, like you said. And I think that unfortunately gets overlooked a lot, especially in the more heavier medical side of the fields, where it's just, well, based on what we know about this condition, you're going to have it forever. That's that. Here's some meds to try to get you through it, and good luck. And it's like, well, maybe we try something else and try to help you out instead of just leaving you to your own devices, And I think that's the cool thing about what you do and what we do is actually helping people function better on that daily basis.
I think so too. And to take that one step further, this is, well, I'll talk about PT. I can't tell you how many times I get patients here that are going to tell me PT doesn't work. I've tried it and this was my experience. And, that used to bother me when I was a new clinician, but I totally understand now. I've worked in enough places and seen, I understand why you're frustrated. I understand why you feel this doesn't work. Let us try it differently and show you, why it's worth the try. And I know you guys are very similar to that too. But again, to take it one step further, that's not even explained to these patients. They're given this diagnosis of Parkinson's. Here's your levodopa, whatever it is that they're going to give them. Be on your way. Call me if you have a problem. And they don't even discuss sometimes, and I'm speaking very generally here, I realize that, but sometimes they don't understand the dosage. That's very important with timing of dosage, timing around activities, timing around meals potentially, urinary, fecal. My wife's pelvic floor. Do you know how many of these neurodegenerative issues cause these things? And they're never even disclosed or discussed. So now I'm getting onto the big platform of we're not talking to our patients. They're not being heard. And neither are their spouses or their caretakers. The people who are taking care of these people. You know how many people, so I'm treating a guy who's got his wife taking care of him, right? And he's 300 pounds and she's 150. I'll treat her eventually because she tried to catch him, and it's like, no one ever told these people, it's natural to try and catch someone falling. But again, where I'm going with this. There's so many things that need to be discussed. And all these patients are given is your medication and be off on your way. It's something you're stuck with for the rest of your life. Peace.
Yeah.
It's frustrating.
Yeah, it's tough, man. It's tough. But, it's why we do what we do, right? It makes our days enjoyable, being able to help people out. So
I have a question for you.
Yeah, sure.
Have you had any opportunity with neuropathy with Parkinson's patients to treat that?
That is a great question. Not off the top of my head.
Okay.
I don't
know
think
it's not always a common symptom, but
yeah, I don't believe not off the top of my head. I can't recall a neuropathy patient that had Parkinson's. We've had a couple chiropractic patients that had Parkinson's, and those have gone well. It's been helpful. And even this is really just kind of interesting since you're asking about this sidetrack as well. So some of the upper cervical work that we do and working with C1, C2, kind of the Atlanto-occipital area. What's interesting is there's a lot of research out there showing, even on Cine MRI, which is really cool. So video MRI, where you can see, so every time our heart beats, we also get a pump of cerebrospinal fluid up into our brain. That happens all day long, and it's constantly nourishing and cleansing out our brain. So the cerebrospinal fluid is this fluid our brain floats in. It's what cleans out all of the toxins and things like that build up through the day. If you notice, like the lymphatic system, you say you see a lymphatic chart on the wall at a doctor's office or whatever, you'll notice it starts in the neck and goes all the way to the toes, and there's nothing up here. it's like we have all this metabolic activity and waste being produced up in the brain. So what's happening there? It wasn't until like the early 2000s they discovered, they call it the glymphatic system. And it's the lymphatic system for the brain, and it's the CSF cleansing that out. And so what's interesting is if people have major misalignments in the upper neck, when that fluid it works on a vacuum system. So if this atlas slides over, we're talking like a millimeter or 2 millimeters, right? These are very minute things, but in our terms, they're large misalignments. So they misalign. We actually can see on Senate MRI where we're getting a huge pump of CSF to one side of the brain and nothing on the other.
Wow.
And then that's leading to neurodegenerative type symptoms, whether that's actually diagnosed as a certain neurodegenerative disease or not. But people are having multiple sclerosis like symptoms and these other type of symptoms that are going on. So we've actually had a couple cool experiences with Parkinson's patients where we've got them under care and fixed specifically like some of the upper neck stuff. And again, we're not curing the disease. We're not doing anything like that, but we're seeing immediate functional improvement where they're like, it's almost like the lights come on for a little bit in their eyes. And it's like, it's amazing to see. It's like they're getting that life back into their brain that they needed. Whether that's just a correlational thing or how long that was there that could have been causing and caused permanent damage to the brain cells, can't really say, but it's a really cool thing and an interesting fact, you know, of how we can affect physiology outside of just pain or just the musculoskeletal system. So
yeah. Well, and all more to the point of get your hands on those patients, right? Just because they're neurodegenerative doesn't mean they're not going to need some type of manual therapy. I mean, at least test, right? Test at the end of the day. And that's, you guys are great at testing, you know, see what they're there for. Because I don't go off on another crazy tangent here. How many times are these people misdiagnosed? You know, Parkinson's is not an easy thing to diagnose. I've had several people who were being treated with dopamine and having no response, and suddenly they changed up the case. Deep brain stimulators. That's another common thing where they'll put, literally they implant something into your brain to stimulate kind of a dopamine response is essentially what it does after the cascade of events. Yeah, I mean, that's not always a good fix either, you know?
Yeah.
So it's good to have a therapist or have a doctor of chiropractic, someone that's also just keeping their eyes on you, right? You're going through these things and going through these changes. But yeah, man, those manual skills, those are.
Yeah. And you're right. Like the misdiagnosis can happen easily because a lot of these diagnoses for some of this neurological based stuff is fairly checklisty, right? It's like, do you have these 5 symptoms? Okay, we're going to say you have this.
Exactly.
Like, it's not a clear cut, defined, maybe blood marker or MRI or whatever. Yeah, some of those things can help, but it's like a lot of times it's like, well, you've got all these things, so we're going to call it this for now. And you're right. Like, I guess the question is physiologically at the root cause. What is that? What is the root cause? How did this start? Because something happened in the body to start this process.
Mm-hmm.
I'm not saying there's always an answer to figure out what it is, but you know, it's got to be there somewhere. Something started this. It doesn't come out of nowhere.
Well, you certainly have to ask the question. Like you said, I like that. You know, there might not be an answer, but if enough people keep answering or asking the question, that's how we grow and get closer to the answer. And, you know, there's things like the Michael J. Fox Foundation and other foundations like that do a great job of, you know, promoting it. And I mean, God, I'm trying to remember, I was looking up stats to try and prepare for this. I think it was 60,000 roughly Parkinson's disease cases per year or something like that are being diagnosed. I think that makes it the first or second neurodegenerative disease in the country, at least.
Is that, I assume that number is increasing over the years?
Yeah.
Yeah.
And again, you know, the foundation does a good job of awareness. That's why we know this, right? The awareness, we're doing a great job with that. But still, there's not enough clinicians.
Yep.
Insurance is always an issue, right? We don't deal a lot with insurance here, but we do take Medicare, which is obviously Parkinson's is more common if you're 60 or older. Can happen as young as 40. Yeah. But there's all those things to consider, you know. And again, people get lost in the mix. Mm-hmm. You know, they're kind of just, here you have it. Like you said, you're given the diagnosis, it becomes your identity.
Yeah.
And then you're standing here looking like, what am I supposed to do now? You know? Mm-hmm.
Man, we could do a whole call on patients owning the identity of their diagnosis, but we'll stay away from that for now. We'll save that for next time. I know one other topic, not to switch gears too abruptly, but I know we wanted to talk about some dry needling. I know that's kind of a specialty that you're kind of an expert in, and I would love to. Frankly, my knowledge on dry needling is very limited. So I would just love, give us, first of all, a brief background. What is dry needling? What are, how does it work? What are some of the common conditions or symptoms or things that where you pull that out as a tool in your tool bag, and just give us some background on that.
Sure. Dry needling is somewhat new to the PT profession. A lot of that has to do with legalities and things like that. It is derived from acupuncture. Okay. And I'm probably getting a lot of people mad at me for saying that in the physical therapy realm, because that's the main question we get. How is it different than acupuncture? And it is different. However, it's the same tools. The needles we use are roughly the same that acupuncturists used. Different gauges, maybe in terms of the girth of the needle. They are called dry needles because there's obviously no fluid coming out of them. Wet needles are like a hollow needle, like an IV needle or something like that. Mm-hmm. With that being said, risk of pathogens, transmission of any type of pathogen, extremely low because of that. Since I'm on that topic, each needle comes in its own container, individual container, okay? And there's a gas inside that container with the sheath that the needle is in. So it is sterile. Every needle is individually sterilized. So I know that's a question people always ask, is this safe? I always wear gloves, that thing. Dry needling itself, there's a lot of different ways to do it, okay? And it's kind of like acupuncture again, where I don't want to misspeak too much. The way I like to do it is not based so much on chi and meridians, right? That's more acupuncture. That's one way to look at it. And then there's trigger points. That's the big one, is dry needling for trigger points. Now, again, not step on anyone's toes here. I've just not found a lot of success in that. Now, I'm not saying I'll never put a needle in a trigger point, but I feel like it's better to diagnose, be very specific with your diagnosis, figure out where the dysfunction's coming from. Then I'm going to figure out if I need needles. So to your point, if it's a rotator cuff issue, for example, I may or may not decide to needle it. Just because it's a rotator cuff issue, though, I will not choose to needle it. Does that make sense?
Yeah, of course.
Because sometimes that's the other thing. It's a tool like anything else, right? Manipulation is a tool. I may or may not decide to do it. Whatever's going to benefit you. Now, with that said, dry needling has become kind of fatty, right? It's a new thing. A lot of people are using it, and the research and success is out there. And I see why people are requesting it, but it's very uncommon to have a patient come and say, hey, I want a manipulation today, or I want you to do traction on me. They say my back hurts, right? I'm getting people coming in saying, hey, my shoulder hurts and I want dry needling. So I have to educate them. Let's diagnose it, see if it's appropriate, blah, 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 blah. Now, getting into dry needling. The main things people want to know, is it painful? There's an element of pain to it. I'm going to use the word uncomfortable more than pain, but if there's dysfunction in that tissue, it's going to be more uncomfortable / painful. I've had hundreds of needles in my body myself, so I know what it feels like in all sorts of places, and it's uncomfortable. Like yourself, Dr. Konas, I have my own injuries, right? I'm not the perfect individual. I don't have the perfect posture. So I treat myself, and Leah treats me all the time with dry needles. And so I have my personal experiences of it helping. A lot of the research that says it's helping. But again, I just want to be clear. It's not a fix like everything else. It's a combination in getting to the solution, identifying the problem and then getting to the solution. Now, sorry, to answer your question. So dry needling, when we put the needle in, right? Whoop, goes into the skin. That's the first point of entry. So we're in whatever tissue we want to be. We're going to go through cutaneous, subcutaneous. We're into adipose. We're going to muscle. Sometimes we get as deep as bone. We try to hit that bony backdrop. So if I'm trying to hit an iliacus inside, like your pelvic bowl, I'm going to go until I hit that needle on the inside of your ilium, which is obviously uncomfortable. It makes people a little squeamish. And even when I'm pushing with the needle, I can feel that hard end feel. When we do that, it's not like I am stretching that muscle or releasing the muscle. It's kind of like planting a flag in the ground is the way I like to think about it. So that needle's the flag. And what that flag is going to do is identify to the brain, hey, this is the point of dysfunction. So at that point, again, you're bleeding. It's a needle going into your body. That triggers the inflammatory response. So you have all these chemical messengers from the central nervous system that go to that area that you are now planting that flag in, i.e. the needle. So you get, these huge uptake of like prostaglandins and bradykinins and, your enkephalins that come down. I mean, it's crazy, right? A histamine response, you do get red, you can itch, you get all these things that don't sound good. Yeah. But this is your body's natural healing process. This is what we do want. When you do get hurt, say I fall and sprain my ankle or sprain my wrist, It's going to swell. It's going to get red. That's not a bad thing. It's bad when it doesn't go away. That's a chronic issue and needs to be addressed. But inflammation is a good thing. And that's essentially, if I'm wrapping this up in a nice little bow, saying that's what it is. I'm creating an acute inflammatory response at that area of dysfunction, bringing all your body's natural chemical reactors to that area to create change and hopefully speed things up. So that's the big thing that I subscribe to and how it works. I can tell you, and this you'll understand this better than me, Dr. Konas, and feel free to speak on it after I say it, but I've had needles in my suboccipital where I was having a headache, for example. So hitting the suboccipital groups in the base of my skull with needles, that pain goes away, my headache's gone. But something I've still yet to understand is why I can breathe better. So every time I get dry needling to those upper levels, for some reason, I take a big breath of air and I'm like, wow, I didn't even realize that I wasn't breathing appropriately.
Yeah.
Any thoughts on that?
Yeah, that's huge. So I love that you said that. And I love how you explain that overall. Before I get to the suboccipital portion, I just really want to reiterate and touch on what you talked about with the way the body heals. So many people are so lost on that just in general, especially in our country, I think specifically because we're so consumed with every other commercial being pharmaceutical commercial and just the way that we treat ailments in the body in general. People think every ailment needs a pill for it, right? I mean, at the end of the day, that's like I think there's a shift like starting to move away from that now because we've gone so far to that side. But it really is true. And like, I like to use a fever as a good example, right? Like you get a fever. What is everybody's instant reaction? Take something to lower my fever. Like, oh, I got a fever. I better take Motrin or I don't know. I better take something to get this fever down. Well, what's the reason that you have a fever? Why does your body produce a fever? It's to kill off whatever's happening in your body. Like that is the mechanism. So if you take something to lower that fever, you will be sick longer. Like that's just the fact of the matter. Like you might feel temporarily better because you're not so achy. You don't have the fever symptoms, but it's just going to prolong the time that you're sick. I mean, that's all it's going to do. Of course, we know there's dangerous levels of fevers. That's not what I'm talking about. But it's the same thing, right? And like you said, inflammation is completely necessary for the body to heal. And so when you have that response, there's a difference between acute inflammation and chronic inflammation, like you said. And I think they've even coined the term because we've gone so far overboard here of how inflamed people are in general too. But like chronic inflammatory disorder is it's like an ICD-10 now.
Yeah.
Because people just live so inflamed. Well, that's chronic inflammation, mostly induced by lifestyle and things like that.
You got it.
But we want acute inflammation. You know, if your ankle swells up, that's nature's cast saying, hey, dummy, don't walk on this thing. It's injured. Like we're going to immobilize it for you. And then it should go down and it should heal. And then you're good to go. You don't want that inflammation out right away. So I love that you said that.
To that point, real quick, I do want to say that you're right. We're changing and it's adapting. I actually did have a surgeon downstate who would do spinal fusions and would not prescribe any type of anti-inflammatory for that reason. It would delay the healing. Just wanted to throw that in there.
No, that's good. I mean, that's a step in the right direction, I would say for sure. Yeah. So with the suboccipitals, I love that. That hits on our upper cervical our stuff here. So what's interesting about the upper cervical, first of all, cranial nerves. So you're looking at all of your cranial nerves coming from the brainstem area. There's a few that pierce the suboccipitals as well. And that actually can be dependent on people's specific anatomy. So what's interesting about anatomy is that there's certain things that are always there, right? We all have like the same muscles attached at basically the same points for the most part, all these things, but nerves are kind of interesting. Different people can have nerves that pierce different muscles. Some might go through the belly, some might bypass a muscle, just depending on which nerve we're talking about. But cranial nerves are a big part of what comes out of the brainstem area there. And then your suboccipital muscles can put tension. So here's a big thing. So the brainstem, which is located right at where your head meets your neck, that's your brainstem. It houses essentially all of our autonomic functions. So that's our breathing, our digestion, our sleep cycle, like everything we don't have to think about to do, right? Now, here's where I think this plays in the most. When we get a misalignment of C1, C2, anything in the atlanto-occipital area, and again, when I say misalignment, we're talking millimeters. Like this is not a massive, it's not like your bones sticking out of your neck, right? So these are very small. But there's something inside the spinal canal called dentate ligaments. Now, dentate ligaments your spinal cord isn't just sitting in your canal. It is tethered by these dentate ligaments to the spinal canal wall. Okay. So what's interesting is they're mostly found at certain levels, and the upper cervical spine has the most. It's very densely connected in there. So it's interesting if we get a slide or a rotation of the upper neck or the bones in there, especially against each other. If we have C2 rotated one way and then C1 rotated the other, it creates this torsion. What you can see on an axial slice of an MRI, like if you were looking straight down your spinal cord, it literally, the cord gets torqued. And your spinal cord is so sensitive, obviously. I think most people know that. But literally, it can get torqued, and then the spinal cord is broken down into pathways, or what they call tracts. And the different tracts control different parts of your body. And so what's interesting, we can see it on an MRI. It'll, it's supposed to kind of look like a butterfly almost, your spinal cord, and it'll get twisted and morphed. And it's literally pulling and stretching on the cord. And the signals are not transmitting properly from your brain down to the rest of your body. And we see it all the time. We'll take the tension out of there. People can breathe better. They're sleeping better. Their digestion improves. And all we did was touch their neck, and they're like, what the heck did you just do to me? And it's like, it's literally, it sounds complex, but it's so darn simple. It's literally just something tugging on something else. And if we take that tension off, and it can actually just start transmitting signals properly, changes people's world, And so, man, I'm glad you asked that, because I could talk on that all day. I won't, but
yeah, that is funny though, because those are the patients that I'll get, after having been with you or a chiropractor, and like, no, it was like a miracle, because it is, when people aren't breathing, they're not thinking of their spinal cord, if they're congested for whatever reason or short of breath, it's got to be the lungs or a sinus, or no one ever seems to think of alignment. And you're right. Yeah. And there's so many of those autonomic issues that are probably just a misalignment.
Yeah. It's cool, man. I love seeing that stuff all the time. So, cool. So, man, this was, I think, super informative for people listening in. I know, actually, I didn't even mention this to you before the call. I had someone message me when we first posted this, and they said, "Hey, I can't make it live. Is this going to be recorded? I want to make sure I watch it. My dad has Parkinson." So pretty cool. I know people will really enjoy this information. What's the best way for people to get a hold of you and reach out to you?
Probably my email, which it's drmario@palominopt.com. But we're all over social media. We're on Facebook, Instagram, same thing. The handle's @PalominoPT. We're here in Traverse City, Home Depot area, for those who know it, off South Airport Road. But same thing. Everything's online, our website. My wife, again, Dr. Leah, she's the Michigan pelvic rehab side of things. So she does all the pelvic floor. Yeah.
That's awesome. And then you guys do, you always offer free consults, right? Free consultations. People can come in, check you guys out.
Yeah, always free consults. And, I need to get better about talking about those, because I think it is becoming a more common thing, Kyle. But the thing is, man, I want the consult, not because it's free or anything like that. I want you in here to know if I can help you, because there's, again, so many misconceptions about what we do or how we do it or where you belong. And every now and then you get someone in here, for example, that's, "Hey, do you guys prescribe medicine?" No, that's not a different kind of doctor. Yeah. But for that reason, consults are a good thing. Go meet your clinician. I don't care who it is. Ask to do a consult. I think they're important.
No, I love that, man. Yeah, we got the same thing. We kind of have this like complimentary spinal severity screening we offer, and same with neuropathy. So just complimentary appointments. You can come in, we can do a brief consultation. We can run just a couple screening tests to see if you might be a good fit for us for what we do, and if we can actually help in the first place. You can get to know us, see if we might be a good fit. And I know you're doing the same thing over there. So, and then also, I know you wanted to ask about ideas for workshops from the audience in the future that you guys can put on. So I think if you guys could post those in the comments here, if you have an idea for workshops, what are topics you guys want to learn more about, whether it's a virtual setting or doing a workshop, over at your guys' office or whatever that is. Hopefully we can come up with some more cool stuff for the community in the future. And I know you and I have talked a bit about really getting providers together and making a collaborative approach in Traverse City. And I know it's what we're trying to do. So I guess everyone be on the lookout for that. See what we come up with in the future here too.
Most definitely. Well said, Kyle. Well said.
Awesome. Well, hey, thanks for being on with me, Doc. And always a pleasure talking with you. And hopefully everyone got something out of this. Share this with your friends, loved ones who could benefit from this. Go ahead and share it with them. And then reach out to Palomino or reach out to Shift, and we'll see if we can help you guys out.
Yeah, it's great. Thanks for having me, Dr. Konas. It was a pleasure.
Of course, man.